This educational initiative will target oncologists, pathologists, and pulmonologists, as well as other healthcare professionals involved in diagnosing, treating, and caring for patients with non-small cell lung cancer. Physicians, nurses, nurse practitioners, and pharmacists may all receive continuing medical education credit for this activity. And now we are pleased to introduce our CME Program Chair, Dr. David Gandera.
I am David Gandera, and on behalf of the International Association for the Study of Lung Cancer, welcome to this World Conference. This is the 13th World Conference held by this association. You'll be interested to know that as of today, we have about 6,000 people registered, which will make this meeting by far the largest lung cancer meeting ever held in the world. So thank you for joining us today. The topic of this symposium is non-small cell lung cancer. Is it now multiple diseases? This is a CME activity. I'll talk to you a little bit more about the filling out the CME forms later. It is sponsored by Professional Education Services Group. As you know, it is provided at no cost to the participants. It is sponsored through a continuing medical education grant by Lilly Oncology. The learning objectives are shown here, so I will not go through them individually, but please take a look at them. Make sure we're doing our job. We have a distinguished faculty. Here's one. Oh, this is me. So I am David Gandera. I am from the University of California, Davis, and I am one of the conference co-chairs for this World Conference. Our other faculty, I could not be more pleased with the faculty that we have for this satellite. They are friends and colleagues, but more important than that, they are world-recognized experts in lung cancer. Dr. Chandra Balani from Penn State, Dr. Sarita Dubey from here at the University of California, San Francisco, Dr. Philip Bonomi from Rush University in Chicago, Dr. John Eckhart from Dava Oncology in Dallas, Dr. Bruce Johnson from the Dana-Farber Cancer Center in Boston, and a recent transplant to the West Coast, Dr. Alan Sandler, and you may expect to see Vanderbilt there, but he is now at the University of Oregon Health Sciences Center in Portland, Oregon. These are our faculty disclosures. And Professional Education Services Group has no financial interest or relationships to disclose. So we're going to begin and actually continue through this satellite to introduce each topic with a case. I know because this is an ISLC meeting that you come from all around the world. In fact, at these meetings, and I think it will be true here, it is approximately 1/3 participants from North America, about 1/3 from Europe, and about 1/3 from the rest of the world. Here at this conference, we have delegates from 87 different countries. So there is nothing like a case to put into perspective the discussion. This first case is a 55-year-old female who is a never smoker. She is a professor of biochemistry at your institution, and she presents with 2 episodes of hemoptysis. When you question her, she says, yes, the blood was red, and when you ask her to quantitate it in regard to a teaspoon, she says that each episode was less than 1 teaspoon each. Her CT scan, a cut is demonstrated here. It shows a mass in the left upper lobe, and it also shows multiple bilateral pulmonary metastases, and there are also bone metastases. The patient undergoes a bronchoscopy, which shows a friable endobronchial lesion in the left upper lobe. It is biopsied, and it is an adenocarcinoma that is TTF1 positive. This patient has a good performance status. She is quite motivated for treatment. You do a scan of her brain, a CT scan, and it shows no metastasis. So the first question for you, and these questions are really rhetorical because we're not going to have you try to answer. The panel, I think, likely will make comments about the cases, but we want to give you some things to think about. So the recommendation for initial therapy. First choice, platinum-based doublet chemotherapy. Second choice, bevacizumab plus a platinum doublet. Third choice, erlotinib single agent. Fourth, erlotinib plus a platinum doublet given concurrently. Or fifth, non-platinum chemotherapy. And you can see the choices you might use below with either cisplatin or carboplatin. You decide to treat with a platinum doublet. Which of the following doublets do you recommend in this particular patient with an adenocarcinoma? Paclitaxel, gemcitabine, pemetrexed, docetaxel, or vinorelbine, all with a platinum. The patient wants to ensure that she will derive benefit from her therapy. She is, after all, a professor of biochemistry. So she goes to the internet, and she seeks information to guide her. And she comes back to you, and she asks that her tumor tissue be analyzed for possible predictive biomarkers of chemotherapy benefit. If you had validated tests for potential biomarkers such as ERCC1, RRM1, or thymidylate synthase, would you assess these biomarkers in order to select her chemotherapy? Yes or no? Tumor is sent for analysis, and the following results are reported for mRNA expression. ERCC1 is low, RRM1 is low, TS is high. With this information, what chemotherapy would you recommend? Would you still select any standard platinum doublet regimen? Would you select a platinum doublet regimen not containing gemcitabine, not containing pemetrexed? Would you go to a non-platinum doublet, or would you offer erlotinib instead of chemotherapy? So for our first discussant, does histology matter with the use of cytotoxic chemotherapy? Yes, because we will have a point and counterpoint here. I asked Chandra Balani to come to the microphone.
Thank you. Good afternoon. Thank you, David. It's a pleasure to be here, and it's a pleasure to see all of you here at the first session. So histology does matter in today's date when we treat patients with advanced non-small cell lung cancer, not only with cytotoxic chemotherapy, but also with various targeted agents. When we look at overall non-small cell lung cancer, 87% of all lung cancers are, in today's date, non-small cell lung cancers, and 13% are small cell. Half to two-thirds of these have adenocarcinoma, and a little more than a third have squamous and other histologies. When we look at adenocarcinoma, as you saw in the case, the patient had glandular pattern and also had TTF1 positive. We also see positivity with cytokeratin 7. Usually adenocarcinomas are cytokeratin 20 negative and TTF1 positive. When we look at squamous cell carcinoma, they have different characteristics: cellular keratinization, intercellular bridges, keratin pearls, and usually the CK7 and CK20 or the cytokeratins are usually not seen, and sometimes they are TTF negative but not 100%. So these are the characteristics of the two common histologies of non-small cell lung cancer. But as you will hear throughout the course of this presentation, this satellite, and also throughout the meeting, there is actually going to be a change in overall perspective, the way we look at adenocarcinoma. Because just adenocarcinoma by itself may not be enough to give appropriate treatment. So in 2009, what we know, at least in 50% of the adenocarcinomas, there is either KRAS mutation, there is EGFR mutation, there is BRAF mutation, PI3 kinase changes, MEK, FGFR, EML, and now we have targeted agents for most of these markers or receptors or proteins, as you will hear throughout the presentation. What have we done over the last 3 decades? When we look at the overall management, there has been a little difference in treatment outcome, because we have primarily used therapeutic empiricism in the overall management of this disease. And we also see increasing number of patients with not otherwise specified histology, whether it's due to insufficient tissue, as this is lung cancer and it's inside the lung, we are only able to get cytological biopsies or just brushings, or whether we cannot really get the pathologist to give us an analytical view of the histology, and they just say, not otherwise specified. And I think as you see what we have to say during the symposium, you'll see that histology does really matter. And histology does have treatment implications, as you will hear, that it is not only the efficacy of various regimens in subhistologies of non-small cell lung cancer, but also as safety determinant. You'll hear from Dr. Sandler that the anti-angiogenic therapies are much safer in non-squamous malignancies or non-squamous histology of non-small cell lung cancer. And we also know that agents such as the EGFR inhibitors and pemetrexed have higher degree of efficacy in patients with non-squamous cell carcinoma. And in patients with squamous malignancies, there is a higher efficacy with gemcitabine-containing regimens or IGF-1R monoclonal antibodies. But that's just a suggestion at the present point in time. So going back in time, when we started this trial in 1994, and with therapeutic empiricism, taking a look at overall all subhistologies of non-small cell lung cancer, ECOG 1594 established that all these 4 regimens, carboplatin paclitaxel, cisplatin gemcitabine, cisplatin docetaxel, and cisplatin paclitaxel, were 4 reasonable first-line alternatives. And we said that have we reached a chemotherapy efficacy plateau? And in fact, it was true that when 2 drug regimens were compared to 2 drug regimens, we did not see an overall improvement in outcome. There was a suggestion from a few clinical trials that the non-adenocarcinomas or squamous cell carcinomas actually respond better to the platinum-containing regimens, and the non-platinum regimens had a slightly higher degree of response in patients with non-squamous cell carcinoma or adenocarcinomas. But this has never been actually validated. And as you saw in David's case, that there was a non-platinum doublet as one of the alternatives, which he mentioned as the treatment for this patient who has adenocarcinoma. As we said, it is already relevant that histology is a safety determinant when we use angiogenesis inhibitors, which we will hear in a few minutes. But there is emerging data at the present point in time from 3 large randomized clinical trials that pemetrexed, which is a multi-targeted antifolate, has greater benefit in non-squamous histology. Now, whether it is just histology or in addition, there is a molecular determinant or a change in the overall receptors or proteins in the cancer cell, which are the result of increased efficacy with pemetrexed, remains to be validated. But pemetrexed, which is the multi-targeted antifolate, has the 3 targets: thymidylate synthetase, dihydrofolate reductase, and GARFT. And from the clinical and preclinical data, we know that there is higher degree of expression of thymidylate synthetase in squamous cell carcinoma, and there is actually a lower expression in patients with adenocarcinoma. And this has been seen both in the clinical setting and also in the non-clinical setting. And this was validated or observed initially in the phase 3 clinical trial where pemetrexed was compared to docetaxel. The subgroup analysis of histologies showed that the pemetrexed-treated patients had a better effect if they had adenocarcinoma or non-squamous cell carcinoma, and if they had squamous cell carcinoma, the overall magnitude of benefit was actually lower. And the second trial which confirmed this and actually led to the approval of cisplatin pemetrexed in patients with just non-squamous cell histologies was the Georgios Kaliatis trial, where it was non-inferiority as the main objective. The two regimens were cisplatin pemetrexed as the investigational regimen and cisplatin gemcitabine as the comparator arm. The trial showed non-inferiority. The median survival was 10.3 months in both arms of the trial. But when they separated patients with adenocarcinoma and large cell carcinoma and compared them to those who had squamous cell malignancies, there was a modest but significant benefit with the pemetrexed-containing regimen in the non-squamous cell histologies. And that led to the approval in that subhistology of non-small cell lung cancer, the regimen of cisplatin and pemetrexed. And more recently, we showed you at ASCO that this observation was confirmed in the maintenance pemetrexed trial, where there was an overall benefit in survival when pemetrexed was compared to placebo in advanced disease patients after 4 cycles of chemotherapy. But when you look at the non-squamous histology patients, there is actually a provocative benefit with a 5.2-month improvement in median survival when pemetrexed is compared to placebo. And that benefit is actually lost in patients with squamous cell carcinoma. And these analyses were pre-specified in the statistical analysis plan of the trial. So from the data of these 3 clinical trials, we can say that non-squamous histology is predictive of the improved efficacy of pemetrexed in patients with advanced non-small cell lung cancer. And in other words, there is a significant interaction between non-small cell lung cancer histology and pemetrexed treatment effect. So one of the choices that these patients could have had is the combination of a platinum pemetrexed regimen. Now, whether it is just histology or is it the molecular marker, we'll hear more by the other speakers, but there is a possibility, and these observations need to be validated from the tissues which have been collected from these studies and from the future clinical trials to see whether TS is primarily the target and whether it is modulated or whether overexpression of TS actually has a decreased effect in patients with squamous cell disease. And also there is data that cells with MTAP deletions in the tumors may be particularly sensitive to agents that reduce de novo purine synthesis. And we know that the mechanism of action of pemetrexed is based on that. So these will be actually further able to define appropriate regimens for patients with subhistologies of non-small cell lung cancer. Now, in addition, you also saw that the response determinants to chemotherapy, which were conducted in these patients, were TS, RRM1, and ERCC1. And actually, further, we can actually look at protein profiles and genetic expression profiles to see whether we can separate treatments for even these subhistologies of non-small cell lung cancer. And you saw that the patient did have a high TS, making her actually not a candidate for a pemetrexed-containing regimen. So I'll summarize in the next couple slides that selecting optimal conventional chemotherapy or a targeted agent, we do need tissue to make an appropriate diagnosis. Histology is relevant, and it is validated in all these 3 clinical trials that agents such as pemetrexed are only effective in patients with non-squamous cell histology. We need to validate these molecular markers which can define further therapeutic decision-making. There is relevance of EGFR-based therapies, and in this patient who's a non-smoker, as Mark clearly asked that question, that there may be a benefit if there is presence of EGFR mutation. And there is extreme importance relative to safety when we use the anti-angiogenic therapies, and there is need for adequate tissue sampling and validation of these molecular markers. So histology does matter when we choose a regimen for patients with non-small cell lung cancer. Thank you for your attention. And to give you the other perspective, our next speaker is Dr. Philip Bonomi, who's Chief of Medical Oncology at Rush Presbyterian, and he'll tell us the other perspective. Phil.
Chandra, thank you very much. You're always a hard act to follow, and especially when you have such a strong position to defend. But I'm going to bring up a few points that may cause everyone to think a little bit about this. Can we say that the predictive value, I'm not going to talk about the prediction as far as safety with an anti-angiogenic agent, but predictive value for efficacy, has it been validated in non-small cell lung cancer for pemetrexed? And is the histologic classification of non-small cell lung cancer consistent? And given these provocative results, I'm guessing there's got to be a molecular mechanism underlying it. Can we do better if we find out what that is? Well, this is the landmark study that Dr. Scagliotti did. And there were, in this, again, somebody could say it's a subset analysis, but it's a huge subset analysis. It's 1,000 patients who got treated with gemcitabine and cisplatin versus pemetrexed and cisplatin. And I'm very convinced that this study, that the hazard ratio of 0.81 indicates that pemetrexed was better than gemcitabine in the non-squamous patients. And then this is a Chandra study looking at pemetrexed as maintenance therapy. And again, you see if you have non-squamous histology, there's a very clear-cut survival advantage. And if you don't have that, you don't have a clear-cut survival advantage. But these are two different settings. The first one is a frontline setting. This is a second line, if you will, or maintenance therapy. And in the second setting here, it's compared against a placebo. So in order to say that you've validated it, do you need to have it compared to another treatment? That's one consideration. Here's some slides from very nice work done by Dr. Sao in the BR21 study, looking at erlotinib versus placebo. And in this case, they were looking at the patients that had high gene copy number for the EGFR gene, so-called FISH positive as defined by Dr. Hirsch and his colleagues at Colorado. And you see if they were FISH negative, they had a low gene copy number, erlotinib seemed to have no advantage over placebo. However, when you looked at patients with a high EGFR gene copy number, erlotinib was clearly better. Well, here's a study that Dr. Kim published in Lancet back in December of last year, looking at docetaxel versus gefitinib in the second-line setting, EGFR inhibitor versus a cytotoxic agent. And in a subset of patients, they had tissue to look at various molecular markers. And in this group, they looked at EGFR gene copy number, they looked at EGFR mutation, they looked at KRAS, and none of those markers could be predictive either for you should go for chemo or you should go for the EGFR inhibitor. I think if you have a predictive marker and you have choices of therapy, you want a predictive marker that's going to tell you, hey, I'm going to pick A over B. Some of the things I think we'll hear from the next several speakers might show some evidence that we have one marker that is pretty convincing. Now, how accurate and how consistent is histologic reading by pathologists out in the community doing their day-to-day work? Well, here is the table from Chandra's paper, and if you go down to the highlighted last couple of rows there, you see that 21% on pemetrexed and 18% on placebo had other or indeterminate type of non-small cell lung cancer, not too much smaller than the number of squamous. So if we have this type of not calling it definitively adeno or squamous or non-squamous versus squamous, is it going to be useful? I don't know that not otherwise specified really makes a difference, but the fact is we don't know that. Then at this year's ASCO, there was a nice presentation headed by Dr. Grilly Olson, and they had a study where they got pathologists who were experts in lung cancer and those who were general pathologists, and they looked at how good they were in deciding whether it was squamous or non-squamous. And again, as they say in their conclusions here, this is probably the first time this type of study has been done, first certainly to my knowledge. And there was moderate agreement, but certainly not perfect agreement. The agreement was better among the lung cancer expert pathologists, and it was better if the tumors were better differentiated. So again, not perfect. Well, one of the things, and Chandra appropriately pointed out, thymidylate synthase as certainly a leading potential predictive marker for response to pemetrexed. And what we see here is early stage patients. We see it's also a prognostic indicator. If you have low thymidylate synthase, those patients did better than the group that had high TS. And Chandra showed the slide also that adenos have a lower amount of messenger RNA expression for thymidylate synthase versus squamous. And when they looked at the correlation between the messenger RNA and protein expression, there was good correlation there. So again, lower amount of thymidylate synthase in patients with adeno versus squamous. Well, here's some preclinical work done by Dr. Hanauska, and he looked at several of the targets that actually pemetrexed hits, thymidylate synthase, GARF, and dihydrofolate reductase, and you can see that the top three are significantly related to greater sensitivity to pemetrexed. Do we need to look at more than one of them? Is thymidylate synthase going to be predictive on its own? Those are things we need to find out. Well, how about other potential molecular markers? Well, here's one that I think is interesting because I think most pathology labs do it fairly routinely, and that's looking at thyroid transcription factor. And that's expressed more often in adenocarcinoma than in non-adenocarcinoma, certainly lower in squamous. And again, these aren't big numbers, but other groups have seen similar things. Relatively low expression of thymidylate, thyroid transcription factor in squamous and relatively high in adenocarcinoma. And here we're looking at sensitivity we're looking at the EMT, epithelial-mesenchymal transition. And what's known is in preclinical studies, if you add TGF-beta, the cells become more mesenchymal, possibly more resistant to chemo too. And if you add thyroid transcription factor, you actually can have them develop a more epithelioid appearance. And is that a group that might be more sensitive to chemotherapy? So certainly I'm hopeful that molecular markers, the hint that we've seen with the histology, is going to be carried forward. And we're going to figure out what the molecular profiles are that are really identifying the people that benefit. Perhaps there are squamous cell patients who have a molecular profile that makes them sensitive to thymidylate or to pemetrexed. So these are things we need to figure out yet. So what I'd say in conclusion, is histology predictive? Maybe. What I think we need is another prospective study in the frontline setting, looking at a pemetrexed regimen versus a non-pemetrexed regimen, and that's actually going on right now. Pemetrexed carbobevacizumab versus paclitaxel carbobevacizumab, very large study. That should give us further information and hopefully will validate this. How consistent is the interpretation by pathologists? Probably fair. And can we come up with better predictors? And I'm the eternal optimist. I think, in my opinion, it's a strong yes, but in fact, probably. You know, sometimes simple things do better than more complicated. So will a marker or a series of markers emerge that really give us predictive value in selecting the treatment for different chemotherapy regimens? We all certainly hope so. Thank you.
Thank you, Dr. Monomi. So we've had a counterpoint now on this issue regarding histology. Due to our time limitations for this symposium, we're going to take questions, but it's going to be at the end of the satellite. But after each one of these case presentations and a counterpoint, we're going to have our other panelists give commentary. So first, I would like to ask for comments on this issue from John Eckhart.
Thank you very much. And you know, in looking at this, I don't know if the first time we're supposed to actually say who won the debate. You know, being actually, as you'll see, I'm at the end of the conference, and I'm a con. I have a little soft heart for Dr. Milani and his opinions. But when I really look at this issue and say, does this matter? One of the biggest things that I think sways me is what's going to happen with my decision point in front of my patient today. One thing I do get is I do get today histology. The second thing I do know is that not that pemetrexed is better in non-squamous. That's good, but that's not enough for me. But what concerns me is this seems to be inferior in squamous histology, and that worries me. because I don't necessarily want to do something that has potential toxicity and could potentially harm my patient. So when I look at this and I look at this debate, I think of the fact that the pemetrexed group that got the squamous did worse than giving other standard therapies. I do want to look at my histology, and I want to avoid using pemetrexed in those that actually express the squamous histology. If better markers may tell me exactly which patients do good or bad, I'll want to see that, but right now I would like to see histology used.
And for second comment, I'd like to call on Alan Sandler.
Thanks, David. So yes, I think that we've heard some compelling evidence of histology matter, that it does matter in terms of using pemetrexed in the non-squamous. What I think would be even more interesting is the theory has been about thymidylate synthase levels and whether those matter or not. And what would be even, I think, even more interesting perhaps, instead of using 17th century technology, the microscope, to determine it, is maybe could we use thymidylate synthase levels? Are there patients with squamous cell histology that might potentially benefit from the use of pemetrexed if we understood what the thymidylate synthase levels were? And contralaterally, are there some folks with adenocarcinoma whose levels are actually higher than anticipated that might not benefit? And so it'd be interesting to look at that forward.
Thank you for participating in this accredited medical education activity. We would also like to thank Eli Lilly and Company for their support of this CME through an independent educational grant. In order to receive CME credit, you will need to pass a CME post-test and complete a CME evaluation form. Upon successful completion, you will be prompted to print your online CME certificate. To continue, please click on the link below this video.